Let's attempt to talk about back to the cost issue with the Massachusetts budget becoming so strained in the last 5 years with the global recession and so forth. So they passed something pretty sweeping. We were hoping to get a member of the Massachusetts House legislator here, but they couldn't make it. Can any of you comment briefly about what Massachusetts did? I believe what they did is they passed sweeping law that several years from now will cap Medicaid spending growth to a benchmark of inflation, I believe. And it essentially, more importantly, gave about 3 different tools to get rid of fee-for-service and replace it with essentially bundled care, whatever you want to call it, ACOs. There was 3 different categories. I guess my question is, can any of you talk about fee-for-service and why that drives excess utilization of healthcare?
It's no different than if you're in a restaurant and somebody gives you a menu and you get a 5-course meal for $60 as opposed to a menu and you're not paying for it and you get to check all the boxes. You're going to have one of everything. It might cost you $120. Every time you go to capitation and you take the risk and give it to some third party, you're going to save money. What the biggest problem with Medicare and Medicaid, and I think the healthcare system is, with all the best intentions, Medicare and Medicaid in most states, it's changing, fixes prices. And so if you go out and give hospitals in Boston or in Medicare and Medicaid, 60% of the revenue of an average hospital comes from Medicare and Medicaid, public programs. And in most states, that's all the government paying you. Every hospital gets paid the same. Massachusetts and most other states to say, look, we're going to give you a flat amount. It's your risk. We're going to give you $36,000.
So it takes away the incentive. Do you think this is feasible? You work at Harvard, fee for service. Yeah. Do you think this is going to work?
I think it could work, and it certainly makes more sense than the current model. Essentially, I mean, right, we create incentives right now for physicians and for hospitals to purely focus on volume. And there's plenty of evidence emerging in the medical literature that a lot of what we're doing is low value, or in some cases even negative value, that we're doing. You know, more isn't always better in healthcare. And I think the medical community is starting to take that on as an actual part of our core mission to identify what are the high value things we do as doctors and what aren't, and try to make sure we stick to the former. But you know, the way it actually will play out is very challenging, because you have to define these units appropriately. What is an ACO? What's an accountable care organization? And the reason this matters so much is because it's not just the cost incentives for volume, it's the lack of cost of incentives for integrated quality care. And if you are a primary care doctor and your patient sees 3 specialists that are all being paid separately from you, and everyone gets paid on how many visits you have, there's no benefit to a specialist of reducing the number of times they have to see the patient by doing a better job. And there's no benefit to me of preventing the need for a specialty visit because I managed one of their issues better. So the accountable care organization offers that possibility, but as always, the devil's in the details, and I think it's an open question.
Yeah, I think in my mind, accountable care organizations, I know a number of them have self-declared as such. They're sort of like unicorns. I mean, I don't think I've actually seen a provider group be able to take risk all that effectively. Some obviously do better than others.
Healthcare Partners in California.
Healthcare Partners and Steward, I think up in Boston, is starting to do some very creative things. But
Heritage in California.
Heritage, asking our providers en masse, both hospitals and large physician groups, to figure out how to become risk-bearing entities for things like Medicaid managed care, but also for actually bundling the care themselves, is a very big sea change that's happening exactly at the expansion.
I know there's a lot of lip service. I interviewed the president, dean of Johns Hopkins and Miami on this topic in 2011, and all of the leaders knew they had to do something for ACOs. They were all talking about it. Has anything really happened?
Yes, hit fast, and it's not. And you know what? To say in healthcare, and I love all health providers. They're all wonderful people, and they're the most honorable people in our society. But it's not the money; it's the money. Money drives everything. And you're in a fee-for-service system, and you're paying every doctor who drives by. If you're in a patient in the hospital, and 6 doctors come by and see you, and they all get paid a visiting fee, that's different behavior than if the hospital's getting a global fee and saying, look, this patient has a heart problem, and you guys are going to have to split up the money. They'll be much more efficient. And when you're going that way, Medicare, when I got to CMS in 2001, then called HCFA, had 3% of people in managed care. Now it's 27%. It's changed the whole dynamics of hospitals for the better. Medicaid has gone from about 20, maybe 15% in that time to 50%. And when you give people a global risk, which is what we're talking about, it changes behavior, it drives. ACOs have been around on the commercial side for a while, and they're basically talking about taking people, instead of paying them on a fee-for-service government price checking list, giving them, you know, $14,000 a year, call me next year. It changes behavior much for the better, and that's where we're heading across the board.
My interest in one state, Massachusetts, is could it take off around the other 49 states? If a respected state with respected medical centers pulled off what they did, in June, I believe it was.
They are way behind everybody else.